You take us away, Nemesis.
Should I start?
Yes, please. Thank you.
Okay. Hi, everyone. I'm Nemesis, and today I will be presenting a topic of electrophysiology, and with me is Dr. Leonel Freites. He is an electrophysiologist in Puerto Rico. He has his own practice called Caribbean Electrophysiology Services. And I will be talking about advances in atrial fibrillation management, which is electrophysiology, Watchman device, and the medications. To begin with, we'll start with understanding what is atrial fibrillation. So atrial fibrillation is a cardiac arrhythmia that causes an irregular heart rhythm and increases the risk of stroke and heart failure. I think you guys are pretty familiar how an EKG looks, and what are the two most common things that distinguish the atrial fibrillation when you see an EKG?
Absent P waves.
Yes. And
An irregular rhythm.
the R
Experiences RRs.
Yes, are irregular. The atrial fibrillation has a classification, and it depends on the duration and length of the episodes. It can be paroxysmal, which is spontaneous, or it terminates spontaneously within 7 days. There's also persistent atrial fibrillation, which fails to self-terminate. And then there's a long-standing persistent, which refers that it lasts for more than a year. And there is also permanent atrial fibrillation, which is where there's a clinical decision to no longer attempt to restore the sinus rhythm. As for the clinical presentation, it varies depending on the patient. But some of the typical symptoms is palpitations, tachycardia, fatigue, weakness, dizziness, lightheadedness, reducing exercise capacity. Some patients may have severe symptoms such as angina, dyspnea at rest, pre-syncope, or other symptoms of stroke or embolic event. As for the risk factors and comorbidities, age is one of them. Hypertension, diabetes, obstructive sleep apnea, heart failure, and obesity. There are some triggers like hyperthyroidism, acute pulmonary emboli, myopericarditis, pneumonia, post-cardiac surgery, and other drugs, and alcohol. Common scenarios for AFib. So this is very common, is that a patient comes in to get an EKG because he's going to have surgery or another thing, and on EKG they notice the AFib. Or a patient with a stroke or other arterial thromboembolism can be found to have AFib that has not been diagnosed. To detect it, the EKG, doctors use the transesophageal echocardiogram, and there are new wearable or implanted devices that can also be used, like the loop recorder. Here's a picture of a loop recorder. The loop recorder is actually the smallest device. The other are the instruments used to implant the device. The loop recorder can record up until 3 years, if I'm not mistaken, or 5 years, I think.
Yeah, that's right.
So I know you guys are familiar with this table. which is the CHA2DS2-VASc score. And this is used to evaluate the thromboembolic risk based on the age and comorbidities of the patient. If there's a 0 score, there's a low risk of an event, so no anticoagulation is needed. If for men, if there's a score of 1, and for women, a score of 2, there's a moderate to high risk, so doctors would consider anticoagulation. This is used when the atrial fibrillation is a non-valvular atrial fibrillation, meaning it's not caused by a mitral stenosis or any cardiomyopathy. As for treatment, so there's rate control and there's rhythm control. For rate control, we use beta blockers and non-hydropyridine calcium channel blockers. For the rhythm control, there is cardioversion, electric cardioversion, which is the CHOC, and then there is antiarrhythmic drugs that the most commonly used are flecainide and amiodarone, at least in Puerto Rico, if I'm not mistaken, right, doctor?
Yeah, Ibutylite is fantastic. It's pretty expensive. It's not really available at hospitals. We use a lot of amiodarone. We use a lot of flecainide. There's a few others, droneridone, which is Multac, and there's Sotalol and some of these other drugs that aren't particularly that great for AFib. I would say amiodarone and flecainide are tough choices.
And also there's something called percutaneous catheter ablation, which we'll be talking about further on. As for the rate and rhythm control, it's preferred rate over rhythm control with regard of the mortality benefits for the patient. There's a target ventricular rate. It's less than 110 beats per minute, give or take. And rhythm is more for a relief of symptoms. There's been comparison of the benefits of rate over rhythm control. Now talking about electrophysiology in atrial fibrillation treatment. So there's something called catheter ablation, which is a procedure to restore the heart rhythm. It's a minimally invasive procedure that targets what is causing the atrial fibrillation. There can be cryoablation, radiofrequency ablation, and pulse field ablation. The pulse field ablation is one of the newest ways, and I believe is faster than the other ones. There was a study published recently that analyzed 57,800 patients, which demonstrated that early catheter ablation performed within 1 year of the diagnosis was associated with improved clinical outcomes. The early ablation led to a 71% reduction in major adverse cardiovascular events, meaning strokes, heart failure, hospitalization, myocardial infarction, and all causes of mortality. It also highlighted that delaying the ablation beyond 3 years of the diagnosis increases the risk of heart failure, hospitalization, and mortality. The next slide is a video. It's really short. I don't know if we have time to show. It's just to show you so you had an idea.
Let me know if you can hear it real quick too. Play.
No.
No.
It's not playing.
No.
Maybe just if you fast forward it, at least you guys have an idea of what it is you can see.
Okay. Here we go.
So I'll give you guys an overview of what's going on. So this is the EP lab. You can see the main operator over there on that person. They're at the right groin. That's where we typically go in through. This is a percutaneous procedure, sort of similar to a cardiac cath. And then we make our way up to the heart, put some catheters in. That's a fluoroscopic view, X-ray view of what the catheters that we put inside the heart look like. This is electrogram, so those catheters that are inside the heart have electrodes, so we get like an EKG from inside the heart. We also make 3D maps of the heart, which is what you're looking at there. And basically, depending on what the arrhythmia is, we go and try and find what the short circuit, quote unquote, is. So this is what the catheters look like. They're usually deflectable. So these are interesting procedures.
This is the pulse frequency ablation.
So for some context, typically we've been using for the past, 20 years, we've been using radio frequency ablation. So radio frequency generates heat, and that's what we use to make these lesions inside the heart that will hopefully take care of whatever the arrhythmia is. More recently, maybe in the past 10 to 15 years, we started using cryoablation, which was using cold, really, really cold, to freeze the tissue and cause the scars or the tissue death that we want to cause. More recently, maybe in the last 4 or 5 years, this new technology called pulse field ablation, which is high voltage energy that gets delivered through those electrodes that you see on the splines of this star-looking contraption. Delivers high energy field, high voltage, probably something around the 2000 volts for a very short period of time, and it does several lesions. What they're doing here is they deliver lesions, then they rotate in several configurations. This energy is particularly targeted towards myocardial tissue and leaves the vasculature, nerves, etc., leaves those alone. So it's sort of a more targeted approach. When you use radio frequency or cryoablation, you can have collateral damage, which in theory you don't get with pulse field ablation. This is much quicker too. I mean, we've been using it maybe since beginning of first year at the hospital where I practice, and our procedure times went from I don't know, an hour and a half, an hour, 15 minutes for pretty quick procedures. We went down to 40, 45 minutes for the average patient. So it's a significant step in the right direction towards procedure efficiency and less time with the patient, which is good. The shorter the procedure, the better it is for the patient usually. In terms of effectiveness, it's more or less about the same though. If you ask Boston Scientific, who makes this particular ablation machine, they'll say it's better.
Thank you, doctor.
Yes,
So,
thank you so much for explaining those videos. I appreciate it. I'm sorry, I couldn't figure out the volume.
so next it's a device-based stroke prevention called a Watchman device. So the purpose of the Watchman is to close the left atrial appendage to reduce the stroke risk. And this is used for patients who are intolerant or are no longer suitable for long-term anticoagulation. There was a study that evaluated the outcome of 48,000 patients who received the Watchman, and they had a CHA2DS2-VASc score of 4, indicating the high risk of stroke risk. They follow up for 5 years, and the study reported a 7% incidence of ischemic stroke and 15% bleeding events. It showed that it validated that the Watchman device is effective as an alternative to anticoagulation to benefits to lower the risk of stroke in patients with high risk. That is the device, the Watchman. And then in here, you can see an example of how a thrombus looks on the left atrial appendage. And the Watchman goes in there. Anticoagulation is still the treatment of choice. There's been advances like the Watchman, and in pharmacological, there has been advancements too, like this medicine. This is called abelacimab, and this is a human monoclonal antibody. It binds to factor 11, and it blocks the activation. So there are still trials going on with this medication, but it's been shown that it reduces the bleeding events and also there's been another study with apixaban, which reduces the stroke risk in patients. There's been emerging therapies for like the semaglutide and medication, but this is for patients who has comorbidities besides the atrial fibrillation. This is still an ongoing studies. There are a lot of studies of research for treatments, being medications or anticoagulations or the Watchman device. I think electrophysiology is advancing, and it has transformed the atrial fibrillation treatment. As I mentioned before, early catheter ablation has reduced the adverse effect of the adverse cardiovascular outcomes, and the Watchman device has been an alternative to long-term anticoagulation for patients. And that's it. Doctor, if you want to add something.
Excellent talk, Nemesis. I have some comments just for the audience. So yeah, so AFib is really common. It's the most common arrhythmia. So, and with our aging population, particularly here in Puerto Rico, it's even more common, right? You mentioned the risk factors: age, hypertension, diabetes, obesity, sleep apnea. These are really common things, particularly in the Caribbean, right? So it seems like most of our patients are at risk for AFib. Um, Definitely, the trend over the last decade or so, when I started training, or maybe when I was in med school, the thought was, well, you see AFib, you can do rate control. You just give them some beta blockers, and as long as the rate is between 60 and 110, it's okay. Now we know better. So recent studies show that the earlier you do rhythm control, the better it is for the patient, whether it be with medication or with catheter ablation. That's not really the point. It's just being in sinus rhythm is what's important, and you avoid a lot of long-term complications that we really didn't know were there. So now, fast forward, last 5 years, maybe 5, 8 years, we've seen all these trials, like the East AF Net trial, like the Castle AF, camera MRI. Some of these trials that show that for certain populations, catheter ablation, early rhythm control is much more beneficial. Not necessarily in terms of mortality, but definitely in terms of symptom control, quality of life, etc., and keeping patients out of the hospital. So, what modality of ablation we use doesn't really matter, really. What it comes down to is, as you guys saw as I mentioned in the PFA video, it's more of a time saver. It's being more efficient with your procedures. It's being able to treat more patients. Many years ago, when RF ablations for atrial fibrillation took 6 to 8 hours, then only do one per day. Now, if they take less than an hour, then you can do several per day. So it's more patients that you're helping, and it's more efficient with your time for sure. So common condition that has a definitely treatment. In terms of anticoagulation, we hopefully these new medications pan out. The abelacimab looks very promising. It's all the benefit of anticoagulant with less of the bleeding, so it seems perfect. We'll see. It sounds to me, just being a monoclonal antibody, it seems to me like it's going to be really expensive. But we'll let that sort itself out. Maybe that will get better as time goes on. And we have a Watchman, which is a great alternative for patients that can't be on anticoagulants because of bleeding, or they prefer not to be. So, and there the risk, when you're on an anticoagulant for many years, right? Your risk of bleeding is however long you're taking the medication, or you carry this risk for a long time. When you do a procedure, the risk tends to be procedural wise. So the risk is immediate. during the procedure, everything goes well. All of a sudden, your procedural risk is gone, and now you're not taking the medication. So now your medication risk disappears. So in the long term, it tends to be better for these patients. There's actually some studies published recently in the last 2 years. I think one was presented at the Heart Rhythm Society last year, where they're talking about doing ablation and Watchman in the same procedure concomitantly, and trying to get Medicare to pay for it, which is always a struggle. So I don't know. It seems to me like the future is bright for both electrophysiology and for AFib management. So thank you very much. Fantastic.
Thank you, doctor.
Thank you so much. We have a member with a question, Mona.
Yeah, I was wondering with the Watchman device, does it need to be like replaced now after some time, or is it just permanent? Does it?
It's That's what I saw. Yeah. Yeah, it's a permanent thing. It's a one-time implant. So what it does is it goes in through a procedure similar to a catheter ablation. We go in through the right groin, through the femoral vein, up to the right atrium. We do a transeptal puncture of the interatrial septum, and we go into the left atrial appendage, and we drop it in. What happens is, within the weeks following the procedure, there's tissue that starts to build up over the device, and that'll seal it. So once it's in there forever.
And is it coated with like Carvedilol or any other medications?
Yeah, it's got a what's it called? Nitinol covering, which sort of decreases inflammation and whatnot, and makes it more friendly for the tissue, if that makes sense. So that when we implant it, it doesn't become as thrombogenic as prior versions. This has been, we're on the fourth version of the Watchman device, and we would see thrombus form on top of the device. That's gone down a lot recently. I think this last version came out maybe less than a year ago.
Great, thank you so much, and great presentation, Nemesis. Thank you.
Very well.
Thanks, Melissa.
Just a follow-up question for the Watchman device. Are there any reasons that a person wouldn't be eligible for it? Other than they're fine taking anticoagulants?
So reason why a patient wouldn't be a candidate for Watchman would be, one, having a thrombus in the left atrial appendage. If you have a thrombus there, you can't get it. You would have to wait for that thrombus to go away. That's a real, and that in itself is a real challenge, because if you think about it, a patient that needs a Watchman will likely have some sort of problem with anticoagulants. So if you have a thrombus in the left atrial appendage, it might be hard for them to take the anticoagulant they need for that thrombus to go away. So that's a challenge. There is some anatomy differences between patients that can make a patient not be a candidate. Too small of an appendage is one. Too large of an appendage is another. It's rare that a patient can't get a Watchman, but I think Boston Scientific, who also makes the Watchman, they report that with the current generation that comes in, they come in various sizes, but with the sizes that they have, they can accommodate 98% of patients. So
That's awesome. Thank you so much. And great job, Nemesis.
Any other questions? I just want to thank you for your time, Dr. Curtis, and joining us today. Thank you so much, Nemesis, for your time.
It's my pleasure. Thank you for having me.
Thank you.
Thank you, doctor.
Fantastic job.
All right, and then for the rest of our meeting, we're just gonna be going over some general things that we want to talk about. We have our icebreaker, our birthdays today. We have some project updates. We have some president VP elect apps coming out, so there's more information about that. Possibly some apparel, and a few other reminders. A moment.
All right, hello everyone. Time for our icebreakers today. So first question, what hobby or activity